Good evening, everybody. At the outset, I'd like to thank AIOC for giving me this opportunity. My video is totally recorded and it's got an audio. It plays for about 7 minutes. So here it goes. Just to go through this presentation. So we have a myriad of different types of cataracts. This particular cataract is a intumescent flocculent cataract. It's a hypermature cataract. And this is a cataract with a hard nucleus. This is a cataract with a small pupil. So these different types of white cataracts are to be dealt with in a different way. And these can be additionally complicated by small pupils as well as by fibrosed anterior capsule. So each of them have to be dealt in a different way. So rhexis becomes probably the most important aspect of mature and intumescent cataract. And you can see the Argentinian flag sign. In these patients, it's always be prepared to prepare the eye preoperatively by using IV mannitol and giving a block if required, and making sure that the intracapsular pressure is reduced. So this is how you can see that the rhexis is extending on both sides. And if such situation happens and you're a capable phacosurgeon, you can extend the rhexis on both sides of the bridge and make it into a slightly larger area for you to do the phacoemulsification. And particularly if it's a soft cataract, you can do a gentle phacoemulsification without, taking care that you do not work in the area of where the rhexis deficiency is, and do a very slow motion phaco and remove the cortical matter as well as the nucleus. And then you can implant a lens inside. This is particularly only meant for surgeons who are very experienced. Alternatively, the most important thing is to prevent it. So here you can see this cataract. As soon as we enter, there's a lot of milky white matter coming out. And using an Utrata forceps, just do a centripetal rhexis, that is pulling the rhexis towards the center. So that's the best thing to do because it reduces the pressure of the capsular rhexis extending to the periphery. So this, once the rhexis is done, then it becomes very easy. This is again a case with a high flocculent cortex and a high intracapsular pressure. So here I'm using a 30 gauge needle to reduce the intracapsular contents. You can see that I have removed quite about 20% of the flocculent cortex. And once you have done that, then the rest of this job becomes easy. You can go ahead and do a rhexis very nicely without any extension of the rhexis. And then you can go ahead with your cataract surgery. This again is an intumescent cataract, and my go-to is using a 30 gauge needle. It's important you fill the bag with a high density viscoelastic like Viscoat. I have no financial interest. You can alternatively use sodium hyaluronate also. And once you have removed a large quantity of the flocculent cortex, then you can go ahead with the rhexis and complete the rhexis without the rhexis extending and creating a problem for you. All these patients are preferably done under parabulbar anesthesia. So this is a case with a femtocataract. Femtocataract is again a very important way of dealing with these hypermature cataracts. And the most important thing is just to make sure that you don't, there are some cut edges which may be left behind. And one of this, the newer advances is a zeptorhexis, where a nitinol ring is used to create a rhexis, and you get a free floating rhexis. So it's a great advantage, and this can be used as a much cheaper option to femto. And the last and one of the most popular ones in our hospital particularly is that using the punchorhexis, where the phaco needle is used to punch not only the capsule but also to reduce the intracapsular pressure and punch the cortical matter as well as the nucleus. Thereby, in one go, it reduces the intracapsular pressure, and then you can go ahead with doing completing the rhexis. It's important that you use a Venturi machine and a 15 degree or a 0 degree trip. So patients who have smaller pupil or who have PAS will need iris hooks to enlarge and then you go ahead with the phacoemulsification. So once you start the rhexis, you can see there's a lot of cortical matter which is coming out. And the problem in this Morgagnian cataracts is the nucleus is extremely mobile. Once it becomes mobile, it's very difficult to do the phacoemulsification and becomes difficult to impale the nucleus. So So it's because they keep rotating in the inside the inside the capsular bag. So this is the lollipop technique, where you catch hold of the nucleus like a lollipop and continue to chop all round. So I actually prefer to use 15 degree or 0 degree tip. In this, it's a 45 degree tip and becomes a little bit more difficult. This again is a patient who has had a mature cataract as well as a hard nucleus, say about grade 3 to grade 4. You can do a simple central trench and then do a karate chop. So at all points of time, you will be able to see both the chopper as well as the phaco needle. And once you have chopped through and through, you can complete the surgery and insert the intraocular lens. So some of the most important tips that you have to learn in a mature cataract is, you have to assess what type of cataract you're dealing with, whether it's an intumescent cataract or a cataract which has got a milky white cortex, or cataract which is associated with the hard cataract, with the hard nucleus, and manage them. Probably the most difficult ones would be where the cataract is intumescent with a shallow anterior chamber, and these patients definitely require adequate care and preoperative as well as intraoperative management. If you take care of all these simple tips, then the results always come out very well and make the patient happy.